Hello, this presentation will be on some of the basic terms that I'd like you to know for this whole class on psychological disorders, given this is chapter 1. Also be talking about some of the history of how people with psychological disorders have been treated over time, and also some of the research methods that have been used in studying psychological disorders. I hope you find this helpful. Okay, stuck. Let's see if I can get, there we go. All right. So one of the first things I would like you to know about is that we do have a diagnostic system that has to deal with psychological disorders. Of course, in the medical world, diagnostic systems have existed for much longer, but also diagnostic systems in the medical world have all sorts of physical ways to back up what sort of malady a person might be facing. I mean, if you have a broken arm, for instance, you can get an x-ray and see that there is a fracture in the bone. With psychological disorders, it's not that simple. So psychologists and psychiatrists and psychiatric social workers and all sorts of people invested in psychological health of the population have tried to come up with a system for diagnosing psychological disorders. And they came up with 3 major criteria for what might be considered a behavior that might be considered disordered. The first of these is the behavior that we're talking about, deviant. That means, is it rare? And just being rare does not mean that a behavior is disordered, because actually intellectual geniuses are rare, but that does not make someone diagnosable with a psychological disorder. So their deviance is one, though, because it's a kind of a red flag. I mean, if you see someone walking around on a 98-degree day with 3 coats on, you might think maybe they don't have any place to put their coats, or maybe that's unusual behavior that needs to be attended to. So deviance is one thing that we look at. Another thing that we look at is distressing. We call these the 3 Ds: deviance, distressing. Distress is like, are the behaviors that go along with what might be considered disorder causing distress to the person who's exhibiting the behaviors, or is it causing distress to other people? And finally, and I think the most important criteria is, are the person's behaviors getting in the way of the goals that they have set for themselves? So for me, that is probably the most critical factor in determining whether behavior is disordered. Because if a person has a goal to graduate from university, graduate from college, but they end up drinking so much that they don't make it to class and they fail out of school, then they probably have a substance use disorder. That's a behavior that's getting in the way of their goals. If they have so many DWIs, they lose their license and lose their job. That's dysfunctional behavior. So I include this picture here, obviously, because this woman taking a picture, a selfie in front of a casket, is deviant. She might have a disorder. Some include a 4th D, and that would be dangerousness. Is that a person dangerous to others? But I have to add that by and large, people with psychological disorders are not dangerous to other people. There's just a small subcategory of people who are diagnosable that might pose a threat to others. Typically, that would include a group like people who have been diagnosed with paranoid schizophrenia, who are not on their medications. But almost all the disorders we'll be talking about all semester pose almost no danger to other people. So I mentioned we will be talking about the history of disorders. I will be just kind of moving through these rather quickly. Hopefully this will be helpful and will add to what you read from the book. In the Stone Ages, what people did was, actually I want to move my picture down here. They drilled holes in the skulls of people who were like hearing voices that other people were not hearing, or because they thought that that person might be possessed by demons, and what they needed to do was create an escape hatch for those evil spirits. They also made the whole body inhospitable to a person who is exhibiting behaviors or hearing voices other people were not hearing. Problem, obviously, in those treatments is that they were often fatal and often killed the person. Drilling a hole is something called trephining, and that allowed, again, just, so it was strange because sometimes people would have a like a blood clot or something, and that relieving the pressure, if they survived the intervention, could relieve headaches and all sorts of other problems. But again, that was not real common. In general, in ancient times in Western Europe, the Greek and Roman civilizations were known to try to address things either with a coherent philosophy or sometimes some scientific methods. One of the first areas that was identified for perhaps contributing to psychological disorders were the balance of 4 major fluids in the human body. And that included bile and phlegm and blood. You can see in the notes that I have there. Hippocrates was an advocate of this kind of approach, and this approach actually held some sway for quite a long time. Also, in Greek and Roman times, people with disorders were often treated very decently. I mean, there was what they call sanatoriums at the time, which we might call mental health hospitals today, included having pleasant environments for people who were distressed to walk around, to be able to move, to do dancing, to get massages. In some ways, it sounds like a spa. And people in those times frequently were treated a little bit better just in those particular 2 civilizations. Also, another Roman physician tried to look for the cause of mental disorders in physical things and looked at traumatic brain injury, that's what TBI stands for, and or drinking too much, or going through a psychological shock, like losing a child suddenly, things like that. Middle Ages were not, I told you we're going fast through history, were not so good in Western Europe in particular. There was a lot of thought that most symptoms of a disorder were caused by demon possession. And although sin was not seen as the cause for most disorders, but still visiting holy sites was a common treatment for people with disorders. What we know is areas that we might consider to be Arabic countries today actually were much more humane during the Middle Ages than most of Western Europe at that time. The first mental hospital in the world was in Baghdad in 792 AD. Asylums then began to be like warehouses, where in larger cities in Western Europe, people with disorders and symptoms, again, hearing voices, having manic episodes, things we'll talk about later on this semester, were just housed and oftentimes chained to walls, given bread and water, just given some hay to sleep on. And I have put up here in this example in London, tourists paid money to walk around and just almost like a circus sideshow, watch the people with the symptoms that were strange. There are other famous asylums in different countries around the world, as you can see in this slide here. And even the 1700s in the US, these asylums, people were told who were housed there, they had to choose to be sane. Fortunately, in the 1800s, probably it was the biggest time of reform for how asylums were handled in the United States. The idea of moral management came along. And this was the idea that if you brought people together and not just house them in an asylum like a prison, but then try to get people to do things that were social and also occupationally oriented, create things. I mean, you could do things from trying to weave materials or build birdhouses, anything that was constructive, productive, and also allowed for engagement with other patients, seemed to actually do better in helping people who had been identified as being somehow unusual or abnormal. One of the first, and so that like I said, that was a whole philosophy of approach in these asylums that really changed to more like mental hospitals in the 1800s in the US. Before that happened, in France, actually, it was a person by the name of Philippe Pinel who transformed some of the asylums into prisons where people were chained to the walls. And he asked, can I unchain these patients? And they said, well, if they cause any problems, you'll be executed. He went ahead and did it. And he found that by letting people outside and having a chance to interact, they improved immensely. And it was really he was kind of a pioneer, a trailblazer in getting people then in other countries, including the US, to try similar interventions in the asylums that existed in the US. Probably the most famous person in the United States who did that was a woman who was a former school teacher by the name of Dorothea Dix. She, right when the Transcontinental Railroad was completed, just crisscrossed the entire United States, advocating in state legislatures about funding needed to transform these asylums into institutions or hospitals that could be used for treatment instead. And 32 state hospitals were started because of her in 20 different states. So she definitely was a pioneer and a social reformer, basically. Unfortunately, as what we've seen historically in the US and in a lot of westernized countries, is that there will be funding and attention to mental health issues for people with disorders as long as the overall economy of the country is going well. But as soon as the economy takes a downturn, the first group of people that typically get nixed from a budget would be people with disorders, because it's very difficult for people with disorders to advocate for themselves. And so you have a problem with being able to say, look, we need more funding for treatment, more staff members, more nurses, more doctors. If so, you're having a hard time concentrating cognitively because of whether depression, PTSD, anxiety. So unfortunately, mental hospitals started to deteriorate, even though they started doing really well in the 1800s. In the 1940s, the National Institute of Mental Health was formed, and the NIMH started to train clinical psychology students. And they created community mental health services in all 50 states. And they had basically patients being treated by trained professionals. However, with the advent of medication, things like Thorazine, which was used to treat schizophrenia, which was actually an accident because it was originally created as an allergy medication, but they found it helped people with hallucinations and delusions. But once they found that there could be a pill treatment for a psychological disorder like schizophrenia, the people in state legislatures were basically like, well, why don't we start passing out pills and defund these hospitals, because it costs a lot of money to hire all these doctors and nurses. So a process called deinstitutionalization happened. And deinstitutionalization meant that people were taken out of their institutions, given medications, basically directed towards their community mental health center, and said, you know what, you have these meds, get a job, get an apartment, you should do fine. And you can see here in this graph, the number of inpatients in public mental hospitals decreased from nearly 550,000 to less than 100,000 20 years ago. And the problem with that is that community mental health centers were not funded very well either. And people were then left to fend for themselves. So a caseworker can only follow so many patients who are in the community. And if you're a caseworker who suddenly has 300 patients that you're asked to follow, there's going to be a lot of people who slip through the cracks. And they're probably typically going to end up homeless and not faring very well for themselves. If what we see even now in 2022 is a lot of times people with mental disorders are arrested for misdemeanor crimes, but end up getting in the criminal justice system and have a hard time getting out, once again, because they cannot advocate for themselves very well. I'm switching from some of the history to some of the basic terms. Some of these will sound familiar to you, probably because you've heard them used in association with COVID-19. Epidemiology, the frequency and causes of disorders in specific populations. That's just the definition of that term. Also, when you talk about the prevalence of a disease like COVID, you can say, oh, how many people had it in a certain year? And that would be like a period prevalence. Um, how many people had a certain point in time, like say last month, that would be a point prevalence. But one of the things that we're concerned about psychological disorders that we look at frequently is what percentage of people are identifiable as having had a psychological disorder at some point within their lifetime. And that's called lifetime prevalence. It's one of the biggest numbers that people in this area are concerned about. Incidence is the number of new cases during a period of time. Comorbidity is another term described in your book, and that is if a person has one psychological disorder, then they also have another disorder. What we find is that about half the people who have one disorder, like depression, are often can meet criteria for having a second disorder, like generalized anxiety disorder or something like that. The term etiology refers to causes of disorder. That's pretty much what the chapter 2 is about. And then we look at the course of a disorder. How do the symptoms play out over time? And we've had another term about the forecast. And I always think of weather forecasters when I think of prognosis, because prognosis is the anticipated course of the disorder. What if you're a family member and you have a person with a disorder, like say schizophrenia, frequently you'll turn to a physician or a psychologist, psychiatrist, like what's going to happen to our loved one? What's going, and so you want to know the prognosis, what's going to be the outcome. Well, in some disorders, especially one as complicated as schizophrenia, there are different courses that occur. And so it has led some psychologists and psychiatrists to conclude that a disorder like schizophrenia is actually a family of disorders. Because as you can see in this graph, basically what you have is that for about 1/5 of the people who are diagnosed with schizophrenia, they'll have one episode of hallucinations and delusions, and they'll return back to the normal level of functioning and not be bothered much later. And then you can see these other groups. A third have several episodes, but can return back to normal. Some will have an initial episode and then get close to normal, but not stay there and have repeated. And some get worse over time. And that's another third of the people who get diagnosed with this. So the courses vary for some of these disorders. And so that changes the prognosis. Sometimes psychologists and treatment providers are left like, we can't give you an exact prognosis for this situation here. So actually, I've been talking a fair amount about how terms are used in this area. But a lot of people think that having a diagnostic set of criteria can be bad. But first I want to identify what might be good about having a system of diagnosis that allows treatment providers to conclude a person has a given psychological disorder. And you can think about that on your own, like what do you imagine might be good or bad about having a system like that? I might mention that the textbook that I've adopted for this class refers to the Diagnostic and Statistical Manual, which is what we still currently use in the United States. Your textbook refers to the 4th edition. Currently in the US, we're using the 5th edition. And I have included a link to a free copy of that DSM-5. It looks like V, but that's Roman numeral 5. For you to, if you want to, look at all the different psychological disorders a person could be diagnosed with. Now, there are some good things about that. You can imagine, like if as a psychologist myself, if I'm referring a patient to another psychologist, it is much easier to say this person that I'm referring to you has been suffering from generalized anxiety disorder. And those 3 words, that summarizes an entire group of symptoms that that person is suffering from. And so it allows for communication. Also with the communication allows for people to set up studies to figure out what treatments might work best for intervening and providing relief for the person who's dealing with those symptoms. So the good about having a diagnostic system is research, communication, and treatment. But you can imagine what might be bad about that. I mean, if you look at some of the bad, one is stigma, and that is basically like discrimination and prejudice against people who have been diagnosed with a psychological disorder. I mean, one of the reasons a lot of people don't seek treatment is because they're worried about the stigma associated with being identified with a given disorder. And there's a lot of research to indicate that someone who has been identified with having a disorder might have trouble getting a job, might have trouble even renting an apartment, all sorts of things. Another downside of that is what's called the self-fulfilling prophecy, is that someone who's told they're depressed might just internalize that label and like, oh yes, I'm depressed, and then think that's the way that they're supposed to act. I mean, it's not a willful acting class that they're doing, but they're just like, oh, this defines me and this is who I am. So sometimes that can lead to more problems if a label is applied to a person and they internalize that label and make that kind of their self-definition. I've talked about this. Good news about stigma is that even treatment providers can be trained to lessen how they stigmatize even their own patients. And so having educational interventions with psychologists and psychiatrists and social workers, I think is critical, so that people, when they're interacting with other people, see the full human being they're interacting with and not just the label of the disorder that the person has been given. There have been several studies called epidemiological studies in the United States trying to determine how frequent and prevalent all these psychological disorders are or have been in the United States. You can see one even included a huge part of the sample from St. Louis, but from all over the country, trying to figure out how common are the disorders. I want to show you a couple charts briefly here. The number that I'm pointing to here with the arrow says that basically the lifetime prevalence, the odds that a person will be diagnosable with any disorder within their lifetime is 46%. That's very close to half, or 1 in 2. So if you can think of all the people you know and think of like, that person can be diagnosed, that person may not be, that person will be, that person will not be. About half the people that we know in our lifetime will be diagnosable. That doesn't mean they will seek treatment or they'll even seek assessment to get a diagnostic label, but they will end up suffering from symptoms of the disorder. What we've seen in the past, probably 8, especially the last 3 years, is the number of people diagnosable with the disorders, including anxiety, depression, and substance abuse, has skyrocketed. And there are a lot of possible explanations for that. Some argue that it's been things like the pandemic. Others argue that it's been social unrest. But the need also for psychological treatment has increased greatly, especially in the past 3 years. So I'll be curious to see if these numbers overall that we've collected in the past couple of decades will also generally go up. These are just how frequent disorders are. If you look at it, in the previous year, 26% of Americans experienced a disorder, again, 46% in a lifetime. Anxiety disorders are a class. So even though I have here that 18% of adults have an anxiety disorder, that's a whole set of anxiety disorders, which includes phobias, panic, and generalized anxiety disorder. 10% suffer from major depression. You see personality disorders are common. Schizophrenia is not that common, but it is one of the most disruptive disorders that we have in the even in the world. And you can see all the other problems that I have listed here. Keep in mind the most common individual disorders are depression, alcohol abuse, and specific phobias. The problem with specific phobias is that if you're phobic of snakes, you just avoid snakes, you don't seek treatment for it. So a lot of people with these disorders don't seek treatment. So I put up there, sometimes people that aren't that bothered by their phobias, they just avoid what they're scared of. Of these disorders, 40% of people receive treatment of any kind. So that's less than half the people who have a disorder will seek treatment. More than 100,000 are homeless on any given day. And you have a big chunk, like I mentioned earlier, they end up in the criminal justice system. I'm a big advocate for the National Association of Mental Illness, called NAMI. My internship class, had 2 interns volunteering there last spring, and it is about advocating for people with mental illness so they do not end up in situations where they're homeless or in the criminal justice system. And that is something that anyone in this class can volunteer to do for the internship class in the spring. I'm going to do a hard shift of gears. We've been going for about a little over 20 minutes, and I'm going to briefly talk about a few research methods. In your textbook that you'll be reading for this class, the research methods are peppered throughout all the chapters. I want to identify a few that I'd like you to pay close attention to, and that includes the case study, correlational studies, experiments, and I'll include in there surveys too, because surveys are an easy way to assess attitudes and even assess behaviors in a much bigger population by having people fill out questionnaires online or on their phone, and you can collect a huge amount of data in a very short and period of time in a very easy way. Case study, let's start with that. One of the most famous cases was a patient, Sigmund Freud's, one of the most famous psychiatrists, actually he was a psychiatrist because he was trained, he had a medical degree. And we'll get into his overall theory in the next chapter, but he studied this person who had all sorts of symptoms that were psychologically based, but they manifested in physical ways. And Freud used the case study to help draw a large number of conclusions about how human personality developed and how disorders developed. Case studies are great that way because it give you an in-depth look at one individual and generate a whole bunch of ideas about where disorders come from, what might contribute to them. The problem with case studies is you cannot generalize from one person to the overall population because there's so many things unique to that one case, that one person. It is a great place to generate possibilities and think about for future research, but it is not a great place to end and draw conclusions about the overall population. Generally, if you're going to do any sort of study, I don't care if it includes surveys or a correlational study or an experiment, you need to follow these steps. And I'll just say this from the get-go, a lot of people can be interested in things like depression and say, oh, I'm just going to come up with a set of questions and go out and ask a lot of people. That's not the way it works. In how material is gathered for textbooks, it starts with people doing individual studies and then having them reviewed by other experts in the area to determine whether they're worthy, whether they follow the scientific method and are worthy of publication in selective journals that are really critical and point out any flaws in a study that might be done. So the studies that get published in our scientific journals are the best of the best. And they're it's where we can really trust the information from the scientific approach about what factors might contribute to disorders and what factors might help alleviate the symptoms in treatment. If a person is going to start a study, they need to go to that literature in the journals, in the textbook, and read thoroughly. They have to become thoroughly familiar with the literature. That is step one. After doing that, being able to pull together conclusions from what a person's read, also leaving their own observations in real life, come up with a hypothesis, typically based in a small theory or a model they've created about what factors might contribute to something like depression. But then you set up a study trying to figure out how am I going to either put people into groups or how am I going to ask all the questions I need to ask in this particular study. So you go out there, figure out what you're going to do. You then, before you actually collect any data, you have to run it by what's called an institutional review board or an IRB. That group will assess whether anything unethical has been proposed to be done, because the number one ethical principle in psychological studies is to do no harm to another human being. For those of you familiar with the Tuskegee syphilis experiments, where African Americans were allowed to die even though penicillin was available for the treatment of syphilis, will know that that ethical principle was championed and came about because of what happened in that study. And now there are safeguards in every school, in every hospital, in every community that will not allow any study to be done where the potential harm can be done to any human being. Once the institutional review board approves of the study, the idea is to go out and collect your data, analyze it, figure out what your conclusions are, and then there is an obligation to report that so the general population can benefit from, I mean, you've asked people to contribute information and data so other people can benefit from that. So that's the overall scientific method right there on this slide right here. I'm just going to refer to this briefly because correlations are referred to again in chapter 2 in your textbook. Hopefully this is review for those of you who have had experimental psychology or even some basic math classes. When we talk about correlations, we talk about two things being associated. And a positive correlation means when two things are associated, as one variable increases, the other variable also increases, but they move together. As one variable decreases, the other also decreases. They move at the same time in the same direction. That would be a positive correlation. A negative correlation indicates that as one variable that you're interested in goes up, the other factor that you're looking at tends to decrease, so they move in opposite directions. Unrelated is a zero correlation. So that's a very, very brief introduction to the idea of correlation. Here's an example of a positive correlation. This comes from the actual research literature, although this is a stronger relationship than you would probably find in a given study. What we know is as people go through more stresses, their scores on depression inventories increase. So if a person has a house fire, they lose their job, they have a car accident, I mean, that's a lot of life stresses together. The more stressors they have, you're going to see the symptoms of their depression go up. So as stressors go up, depression levels go up. That is a positive correlation. Also, as I mentioned before, as the number of stressors goes down, a person's self-reported depression levels go down. That is still a positive correlation because they're moving in the same direction. A negative correlation is the flip-flop of that. And we know from a whole host of research studies that as a person engages in rigorous physical exercise, it tremendously helps their depression levels go down. So more physical activity, lower depression. Actually, the research indicates that that is just as good as the antidepressant medication. The biggest problem with that is, as a therapist myself, when you ask a person who's depressed to go out there and exercise, they look at you like maybe you need treatment yourself, because getting out of bed is sometimes the hardest thing to do. A zero correlation would be like IQ and depression scores. We have people who are super bright who are depressed. We have people who are not so bright get depressed, and everyone in the middle. Intelligence has nothing to do with depression. And so we'd say those two things are unrelated or uncorrelated. A couple other things to be familiar with, and I'm not going to go into all the details of this, but there are a lot of treatment experiments that are done. And an experiment involves randomly placing people into groups and then trying different levels of a treatment for each one of those groups. So if I was coming up with a new antidepressant medication, and I would go out and recruit people who have said they are depressed, I would have to randomly put them into groups because I can't have all the most depressed in one group. That would mess up my study. So I'd randomly, and then I'd give different levels of my new antidepressant medication to each one of the groups. So group 1 might get 10 milligrams. Group 2 might get 20 milligrams a day. Group 3 might get 30 milligrams a day. And group 4, you would think it would get 40. But one thing that happen in experiments like this, especially for new medications, is one group is given what's called a placebo, which is basically like a sugar pill. It is something that a person is given. They may think it's going to have an effect, but in actuality, there's nothing to the actual intervention. You can imagine, and that group is typically called the control group because they're not receiving any intervention, even though they believe they might be receiving it. The reason for that is you want to know if the people in those other groups, 10, 20, 30 milligram, if their depression levels decrease significantly differently than the group who's just given sugar. Because if they don't, then the pill's not any good. So you really have to check out your comparison to what's called the control group who's given that placebo pill. Another thing that happens is we have what's called masked or blind research designs. The people who are in those different groups in that study I just described are not told what level of intervention they're given, or even if they're being given the placebo or the intervention, because just the expectations of receiving intervention can change what a person expects and then how they report that they feel. So typically, not only are the patients kept ignorant of what if they're being given an intervention, but even the people who are providing it may not know whether the patient is being given a placebo or a real drug, or what level of the drug they're being given. One final notion in the research, I mentioned that the Institutional Review Board looks at a number of different variables and before they can approve a study. The first is no one gets harmed. The second is that people have to know what they're getting into. So you know what consent is. It's talked about all the time. So informed consent means if you're going to participate in a study, you know what you're getting into. So you can actually give your yes, I will do that. But also a person's participation in a study is always voluntary. They can quit anytime without being penalized at all. All the information you give is being kept confidential. That's the fourth criteria. And I mentioned earlier that the criteria, that the outcomes of the study have to be explained to the general public because you ask people for their time. And that is the conclusion of the video presentation on chapter 1. I hope you find this helpful.